So we've been talking about this amazing technology, but how does it work then with gastrointestinal issues? The GI tract and all that.
Okay, the GI tract is handled just a little bit differently than respiratory DNA analysis. With the respiratories, the sample handling is very, very simple. The little swab, you pop it in the tube, send it to the lab. Not a big issue. With GI, it's a little bit different. Not tremendously different, but a little bit different. The sample that you get is going to be very important that it be, let's say, adequate. So you're going to want the patients to give you a stool sample. Okay, so it could be one of those little hat things, those plastic hats that we're familiar with. It could be a bedpan that works just fine. Or it can be a simple digital rectal examination. You go put a pair of gloves on, you go ahead and you grab a little piece of stool from that, and then rub it on the brush, pop it in, and go. What the GI samples do for you, it's very, very interesting, is it gives you a handle. It gives you the ability to address infectious diarrhea in a closed environment. What does that mean? Somebody walks in your office and they have persistent gastrointestinal issues. Good candidate to see whether or not they have a slow-growing bug. It does work. But more interestingly, okay, is when you're dealing with closed-in populations. Closed-in populations may be something more like prisons. We do that work now. They may be things like college dormitories. Possibility. So it's unlikely that that's going to be much of a source of this sort of thing. However, when you're dealing with assisted living facilities, this is the population where one person gets sick and then pretty soon you have a lot of sick people. Now, we're all in the business of dealing with sick people. But part of the business is keeping the sickness as minimal as possible. Otherwise, you're going to find yourself working harder with less for more. So what does the gastrointestinal DNA analysis do for you? It gives you the ability to isolate a patient when appropriate and not isolate them when they're not appropriate. Just because somebody has diarrhea doesn't mean that they have to be put on enteric precautions until you know that it's actually an enteric bug. Oddly enough, patients will develop diarrhea when they don't have GI infections. Don't believe that? Give them an antibiotic. See how it works out. Okay, you can give them any number of medications, including antidepressants, which will cause diarrhea and or constipation. We can make people sick. We can make them look like any number of different things, and yet we don't really know what we're treating. So the DNA analysis of the gastrointestinal tract is particularly valuable in the assisted living facility community. The same bugs, okay, will also infect the skin. Wouldn't you know it? So you can do skin analysis using the same device, the same technique, and basically the same panel. So what bacteria are going to give you an infection in a sacral ulcer, decubitus ulcer? Oddly enough, when you think about it, it's not so odd, they'll be the same bacteria that you see in the gastrointestinal tract. So you can use the same technology to get the same thing done. So wound infections can be handled with exactly the same technology. It is very, very interesting. And with regards to antibiotic and other treatment protocols, procedures, mechanisms, and approaches, this gives you the ammunition that you need to actually adequately treat the patient. You become the best very, very quickly. With Florida Laboratory Analysis, as the technology improves, so does the test menu. It works very, very interestingly. So you're able to be the best, a whole lot better than you are right now, with very, very minimal training, with very, very minimal investment, like none. But the data that you get is spectacular. The presence or absence of an infection is no longer guesswork. It's no longer calling a doctor on the phone. Gee, Mrs. Jones is coughing. What do I do? I go ahead and give him some Keflex. That's a fast way to end up with a sicker patient in about 6 weeks. That is not smart. So a whole lot better would be to call the doc up and say, hey, patient looks like they're developing a URI. Can we get an upper respiratory swab? Looks like the patient is developing diarrhea. Can we get a DNA swab? Know what's going on by the time you come in tomorrow morning on rounds or next week or whatever the time frame is. And now you've got something. Your skin infections, urinary tract, same thing. But the gastrointestinal tract is most valuable, unbelievable value in the assisted living nursing home facility. It's just the way to do it, only way to do it in my opinion.
Yeah, I can especially see for a nursing facility like that where it's so important to narrow down exactly what it is and what it isn't, because I can think of any of a dozen medications off the top of my head where it's either diarrhea, upset stomach, constipation, or something else. And At the end of the day, GI issues at the basic level, either it's going out one end or the other, but there's not a whole lot to differentiate them.
Well, what about foodstuffs?
That was just about to say, and then there's just good old-fashioned, badly cooked food.
It doesn't even have to be badly cooked, okay? So it's bad selection for an individual. Okay, so let's say that you've got somebody that has a gluten sensitivity. Okay, and most people that claim to be gluten, have gluten issues are just simply sensitive. Gluten itself is not one molecule; it's a family of molecules. Okay, and not all of them will cause irritation in any one person, but in sufficient quantity, gluten has the capability of making anybody ill. Well, I can eat 1 or 2 pieces of pizza and I do okay, but as soon as I eat the third one, I get sick. Or I can eat sourdough bread, but I can't eat rye bread, or whatever it happens to be. I do well with macaroni, but not spaghetti. Why? Because farina, semolina wheats are different, okay? And the proteins, the glycoproteins, the glutens are different. So you can give somebody diarrhea. You can do all kinds of stuff by simply giving them a food that is not tolerated or in dosages that aren't exactly tolerated. Now, why do I think about food in terms of dosages? Because that's exactly what you're doing. It was written thousands of years ago, let food be thy medicine, okay? It's never been any less true than it's just the way that it goes. You can make people better, you can make them sick based upon what you feed them. But in a facility like an ALF or a nursing home, these sorts of facilities, you also have cost constraints. You can't be giving everybody filet mignon when they have a need for protein. It's not going to work. But you have individuals there that will develop diarrhea from eating the wrong type of meat by virtue of the fact that they don't have a gallbladder anymore, or they have gallstones. So now you have diarrhea. You need to know whether it's infectious or not, or whether your dietitian made a mistake, or whether or not you're dealing with an incomplete database, which, by the way, is something we all deal with. You're looking at a patient. You don't necessarily know their entire medical history. You don't memorize it. You're going to be sitting there dealing with 30, 40, 50 people a day. It's hard to remember whether it's Mrs. Jones or Mr. Smith that has the gallbladder missing, okay? And so you're going to have data breaches. You're going to have problems where you don't have enough data to adequately or appropriately analyze or treat your patient. This is one more tool to fix this. Now, it's nice in a perfect world to be able to tattoo across somebody's forehead all of their problems. Okay, it doesn't work. Okay, but you can do this in a pinch. So you've got yourself an issue where somebody has a sore. I had a patient yesterday, recently, depending upon when you hear this, okay, who ended up with a cellulitis of the leg. Okay, bumped the knee, ended up with a bruise. The bruise then becomes infected. Okay, so you have a decision to make at that point. Okay, how do you treat the cellulitis? Is it just irritative? Is it infectious? Okay, back in the day, we were just simply doing aspirate, find out whether or not it's a strep, work with it from there. Find out if it's a staph, work with it from there. See if it's a cell wall deficient organism. When you're dealing with the gastrointestinal tract, you now have the capability of knowing whether or not it's bacterial, whether it's a overgrowth, whether it's parasitic, whether it's viral. Now, you would know. You'd have to know that the treatment is different. It may be something as simple as giving somebody a tablespoon of castor oil to fix the problem before you start giving people anti-parasitics. That is what this is all about. The difference between 10 cents worth of castor oil or $300 worth of azithromycin. It doesn't make a lot of sense to be making mistakes in this environment, and especially when you're dealing with people's lives. People check out. They die all of the time through misdiagnosis, oversight, and lack of concern. What this does is it gives the average clinician, it gives just anybody out there with a sense of purpose and meaning, the ability to do a better job. This is how it's done. Why do you do it? Where do you do it? When do you do it? You don't want to be doing this on everybody. You don't need to do this on everybody. But you end up with 3 patients on your ward with the similar symptoms. I'd suggest that you go ahead and get it done. Okay? The sick people may be the people that you think are exposed. Why? Because you don't want to have to be dealing with an epidemic, which is really what happens. You end up with wards full of people getting sick. It happens all the time. You can transmit infection from patient to patient. It happens all the time. Simple things like the tie that you're wearing. I haven't worn a tie in my clinic in 40 years. Why? How many people do you know that take their ties to the dry cleaner on a daily basis? That tie gets into all kinds of things. You will transmit the disease from patient to patient. You can wash your hands, but the doc didn't wash his tie. The same thing is true of purses, cell phones, and all these other things. So infection is something that has got to be first and foremost in your mind. And in epidemiology, in these sorts of environments, there's something called a vector. Now, a vector is the means and mechanism that the disease is transmitted. Okay, it could be a mosquito if it's malaria. Okay, it could be a fly if it's trachoma. There are all kinds of interesting vectors in nature. We have become, as doctors, nurses, and technicians, vectors of disease transmission. Gotta love it. Isn't that interesting? So not only are we trying to help people, but we're making them sick at the same time. It's time that we break this up. It's time that we change the way we do business. It's time that we change the way we do medicine. That's what this is all about.
I think it's really amazing the two different major advantages you get, where not only are you able to narrow down what it is, if it is something infectious, more importantly, I think even, is the ability to look at it and find out it's not in fact something infectious, so you don't have to worry about going overboard on everybody else.
That is the message.